Okay, welcome everyone. Thank you for joining us today. We are excited to have uh, you at today's Meet to Expert program. In the next 1 hour, we have an exciting topic, the retained lens matter. Today, our guest speaker is Dr. Saliya Pathirana, a senior consultant eye surgeon and vitreoretinal specialist at Gordon Care Hospital. I believe the insights and knowledge shared by him will be valuable to each of you. I want to thank you, sir, taking the time out of your schedule to be a part of this virtual gathering. I encourage you to actively participate by asking questions in the chat, or you may ask questions verbally at the end of the session and making this most of this opportunity. Without further ado, I want to invite Dr. Sali Patirna. Sir, please. Right. Yeah.
Okay, good evening, everybody. Now, my topic is to discuss about the retained lens matter. So, usually for the retained lens matter, we have to do vitrectomy. So, that's why I have put the topic as vitrectomy for complicated cataract surgery. Kusum, can you hear? Okay.
Yes, sir. Yeah.
Are you
We
all,
can hear you.
you all can hear?
Yes, sir, we can hear.
Okay. Now, I'm going to discuss this topic under two headings. One is management of the posterior capsular rupture. That is, once you rupture the posterior capsule, you will get retained lens matter in the anterior chamber. So the management is I'm going to do. And next, number two, the management of dislocated lens matter into the vitreous. So you get retained lens matter in the vitreous. So I'm going to discuss that topic later. So first, we'll go into the capsular rupture. Now, posterior capsular rupture can take place due to different reasons. Number one, at the beginning itself, due to vigorous hydrodissection. And this happens especially if you have a small capsular axis and you push the fluid fast, it can rupture the posterior capsule during the hydrodissection itself. Then, of course, you will notice that the nucleus is sinking at that time. Of course, during the phacoemulsification itself, there can be a capsular rupture. Then the third is, of course, even an experienced surgeon, he will do the phacoemulsification properly, but at the time of insertion or rotation of the IOL, you can have a ruptured capsule. So how do you suspect when there is a posterior capsule rupture? Number one is you will find sudden deepening of the anterior chamber. And then number two, suddenly you will find that the aspiration ability is lost because the vitreous comes between the tip and the lens fragment. So lens fragment won't get sucked in and into the tip easily. Then you have to suspect that there is a vitreous in the AC. Number three, you might find that the lens is moving in the anterior chamber very fast. There is excessive movement. Rather than getting sucked into the tip, it gets propelled. So there is vitreous in the AC. Now, number four, another very important thing is you will suddenly see a sharp red reflex.
Yeah. It's okay, sir.
So if you suddenly realize that there is a posterior capsular rupture, you have to avoid the AC collapse. Number one is to prevent AC collapse. Because if you take the probe out, the vitreous AC will collapse and the vitreous will get pushed forward. So the capsular rupture will become enlarged. So number one, don't remove your tip. Keep the foot pedal and position one and keep the irrigation going. And you take the OVD into your left hand or whatever the non-dominant hand and inject that OVD through the side port while slowly reducing the inflow from the tip. Now, once you fill the AC with viscoelastics, you can push the capsule and the capsule ruptured area back. And then just check what is the extent of the capsular tear. Is it a smaller tear or is it a larger tear or whether the posterior capsule is totally torn. Now, then check how much of lens matter is remaining, whether the whole nucleus is there or little bit of lens matter is there. And your next management depends on all these factors. Now, if you see, the majority of the nucleus remains. I think you should stop the phacoemulsification. What you can do is enlarge the incision and remove the nucleus fragments using a capsular forceps or vectis. Of course, vectis can cause a lot of damage. If you can use a forceps and slowly remove big fragments, it's much better. Of course, if the vitreous is mixed with lens matter, vitrectomy should be done. Of course, you should repeatedly inject OVD without irrigating. Sometimes you can cut the lens matter with the use of AVD, injecting OVD frequently. And you have to remember, if you're using the infusion line, reduce the bottle height to the minimum, at least to 730. And then start doing the phacoemulsification. If you are sure that the vitreous face is not damaged, then it's much easier to remove the lens fragment. Whatever you can remove with the phacoemulsification, if you are worried, use it manually remove the lens fragment. So small lens fragments can be easily removed manually. If you find that there is small amount of nuclear fragment present with a small capsular tear, you can use OVD to cover the capsular rupture, elevate the fragments with the OVD, and you can use a lens glide. Or actually, what I do is sometimes if everything is okay, if I find that enough capsule is remaining, insert the implant. IOL implantation can be done. And once the lens is there, it will cover the capsule ruptured capsule. So use your phaco tip and you can cut the remaining lens matter above the IOL. Lowering the bottle height at this stage is very important. Of course. Okay, now I'll start again. If there is nuclear material fallen into the anterior vitreous is the next step. Then what you can do is perform anterior vitrectomy. Remove the cortical material and vitreous in the anterior chamber. And you can use the AC. Now, if you find that there's a certain amount of lens matter fallen into the vitreous, don't ever try to go through the pupil and cut the lens matter. Don't fish in the anterior vitreous. They say don't try to fish in the vitreous. You might pull on the vitreous and cause retinal damage and retinal tears. So if there are any lens matter remaining in the vitreous, you can see through the pupil. Don't try to fish them out. Try and remove the lens matter which is in the anterior chamber. Clean the anterior chamber. If possible, place the IOL and refer the patient to a vitreoretinal surgeon. Of course, some people suggest to go through the pars plana and inject some OVD and try to get the lens matter into the AC. But I don't advise to do that. That some experts advise this. Implantation of the lens. You can do in the bag depending on the remaining capsule. If the remaining capsule is sufficient enough to hold the lens, especially if the inferior part of the capsule is remaining, I think usually it's safe. But if the inferior lens the bag is damaged, there's a chance that the lens might fall into the vitreous. So if the half of the lower half is intact, very high chances that the lens will remain. Otherwise, you have to think about sulcus insertion. Of course, number one, remember rule, if you are doing a sulcus insertion, don't use single piece lenses. They will damage the iris and angle later and patient will get glaucoma. So always use a 2-piece IOL in the sulcus. Then you can use AC IOLs. I have used AC IOLs so many times in the history. There are so many good AC IOLs. I have some patients who have had AC IOLs. They are for 10, 15 years, they are doing very well. So don't be hesitant to put the AC IOL if there is a chance. But of course, nowadays, very rare to find AC IOLs. Next is scleral fixation or tucking. So you can do that once you clean the vitreous lens matter. Now this, I'm going to show you a video, which is one of my cases. Now, once I'm doing this, I found that there is a 6 o'clock to 12 o'clock, 12 o'clock, 6 o'clock lens capsule rupture. So what I did is the number one rule, don't pull the irrigation out. And in this case, vitreous face is not disturbed. So could easily remove the lens fragments. And then finally, with the left hand, I injected the OVD and covered the gap. And managed to keep the AC intact without vitreous collapsing into the AC. And slowly injected And I thought I can manage to keep put a two-piece in IOL into the bag. So don't do wound assistant IOL insertion at this time. Enlarge the wound and do it slowly and go directly into the bag. And if you are there, that's it. You are lucky. And this case will do well. I'll fast forward it a bit. That's actually usually what happens is in a heart attack, this last fragment only will cause you problems, right? Unless you reduce the phaco power and the aspiration, sometimes you can rupture the capsule at this stage. Very careful, be careful at the last fragment. And at this, in this case, that suddenly a capsule rupture occurred. You can, it's not really seen, but if you look at the above the lens fragments, you can see a small lens, the capsule rupture. So I injected OVD through the side port and try to keep the AC intact. And at this stage, what I thought was, I will put the lens in to cover the capsule rupture. And then stabilize the vitreous. And then use the phaco probe to cut the nuclear fragment. That was safer because now the capsular ruptured capsule is covered with the lens. This is another technique which you can use when you have only one small fragment is left. Another tip is, another thing what I'll tell you is when you have this type of fragments, and if you are not putting the IOL and doing the phaco, remember, don't fragment it. Because if you fragment it, small fragment can drop into the vitreous. Try to catch the whole fragment and phaco it, rather than trying to break it into pieces while you have a small capsular rupture. Because with the capsular rupture, it's better to catch the total lens fragment and phaco it, rather than trying to break it. Because if you break it, a small fragment will get released into the vitreous. So this is another way of preventing vitreous loss and managing remain lens fragments. Now, this is a case which I have actually recorded from AAO meeting, which very good, the expert explained this. This is a patient who had a posterior polar cataract. And in this case, you can see suddenly a red reflex has appeared in the center. That means that's a ruptured capsule. But he was suggesting is slowly inject viscoelastics and cut the vitreous in the center. Then do a dry aspiration under viscoelastics. Slowly take the lens matter out, inject viscoelastics. Made better to use the dispersive viscoelastic. Then aspirate the lens matter, inject viscoelastic, cut the vitreous repeatedly. Do this procedure. Cut the vitreous, inject viscoelastics, cut the vitreous, inject viscoelastics, and inject triamcinolone to see where there is any remaining vitreous. The triamcinolone will stain the vitreous. Now, there is a good sulcus remaining, so you can inject the lens. And remember, when you inject the two-piece lens, inject into the anterior chamber above the iris. It's much easier. Inject it to the iris, on the iris, slowly manipulate it into the sulcus. The easiest way is to inject it onto the iris. And remember that enlarge the wound. Don't try to do wound-assisted injections at this type of cases. This is another case. Now, this is, of course, one I have copied. Again, this resident is operating while the senior surgeon is watching, and he ruptured the capsule and how they managed the case. Sorry. I think I can't fast forward it. I will just watch it. It's only a few minutes. He is doing the grooving now at the beginning, and then making the tunnel. It's going very deep. Sometimes you can even cut the capsule if you're inexperienced during the making the tunnel. Of course, in my whole life, I have never had that experience. Now you can see that there was a ruptured capsule, and he's pushing that, he ruptured the capsule. Sorry. Unfortunately, I can't fast forward this. I'll show you the. Now you can see the ruptured capsule in the center. But they slowly try to take the lens matter out, use the phacoemulsification. But make sure the main thing is don't stop the irrigation. Get the irrigation bottle lowest as possible. And slowly keep cutting the lens matter, because you can see that the vitreous is still not collapsed into the vitreous. If the vitreous comes in, you can't do this for phaco. It will disturb your surgery. There are some technical errors there. Anyway, what happened was, the main thing that you have to learn is, if the vitreous face is intact, slowly reduce the bottle height to the lowest level and try and do your phaco, continue your phaco. Use enough viscoelastics to prevent the vitreous collapse. Hello, can you hear?
Yes, sir, we can hear you.
Now I will move into the next subject. If there any lens matter dislocated in the vitreous, how can we manage it? Now there are certain problems associated with lens matter in the vitreous. What are these problems? Mainly, of course, this can happen with the phacoemulsification. When there is, even during the ECC, it can happen, but of course, during the ECC, mainly the whole lens will go into the vitreous. Of course, nowadays, because the phacoemulsification is so common, and of course, same time, the surgeons are very much experienced now, not like at the beginning when we started phaco. This complication is very rare now. Surgeons are so experienced, very rarely people have problems with the lens in the vitreous. Of course, this happens with the less experienced surgeons still. The risk factors are there. If the pupil is small, you will struggle and sometimes rupture the capsule. Or the nucleus is very hard, so then hard nucleus, last few fragments might go into the vitreous if you don't manage it properly. Then traumatic cataracts, they can already have some sort of a damage in the posterior capsule. Or some people today, there are so many intravitreal injections we are giving. I have seen some surgeons who have damaged the posterior capsule while giving the intravitreal injection. And those people, you have to be very careful doing a phaco, because there will be already there is a small scratch in the posterior capsule. And of course, in the deep set eyes, the surgery is difficult. When the patient is not cooperative and moving, and pseudoexfoliation, the dilatation is difficult, lens is not stable, so chance of vitreous, the lens fragment going into the vitreous is more. And of course, there are patients with zonular weaknesses. When you try to do phaco, you can have a chance of getting a lens fragment going into the vitreous. Now, I have my own experience. I had a patient who was 80 years old, and it was theatre sister's mother, Morgagnian cataract. I did the vitreous, I did the phaco, managed to do the whole thing, but finally, last small fragment got into the vitreous. And I thought it will remain that nothing will happen. But remember, if there's another question, another point is, if the lens fragment is hard and small, chances of giving trouble is less. If the lens fragment is bigger, again, the chances of giving more problems more. And the soft lens matter causes more problems. So I thought that small hard lens matter will not give me trouble. But few months later, patient came with severe red eye and inflammation. So I had to use anti-inflammatory drugs, anti-glaucoma drugs, and finally did a vitrectomy, remove the lens fragment, she was fine. So main problems with this lens matter in the vitreous is vitreous inflammation, severe vitreous inflammation. And that will elevate the intraocular pressure. And same time, patient will get corneal edema. Then, of course, the lens fragments in the vitreous can cause retinal tears and detachments, and then vitreous hemorrhage. Those are the complications of lens fragments in the vitreous. Now, what is the role of the primary surgeon? When you have a capsular rupture and then the lens matter gets released into the vitreous, don't panic. Don't try to catch the vitreous lens fragments in the vitreous. Minimize your attempt to retrieve intravitreal lens fragments. Use viscoelastics. Try and elevate the fragments and try and take it out. But if it has got released into the vitreous, don't try to fish them out. Anterior vitrectomy and removal of lens fragment is recommended if you are experienced enough. Of course, if you can place the ACIOL or a PCIOL and refer the patient to a vitreoretinal surgeon who can tackle the lens fragment in the vitreous. Of course, treatment of intraocular inflammation and increased IOP should be started straight away whenever you see the inflammation. Of course, you can't go in and do a vitrectomy if there is a corneal edema. So you have to get the inflammation under control, pressure under control, and then only you can go into the vitreous. What are the indications? Yes, you can observe, as I did with my patient, small hard lens fragment went into the vitreous, you can observe. There is a chance it might get absorbed slowly, but you have to keep observing patient regularly to see what's happening to the lens fragment. But if there is a chance of severe inflammation, of course, you have to intervene and close follow-up to watch whether there's inflammation or raise intraocular pressure. When it goes uncontrolled, it's time to do a TPPV. What time? The indications for pars-plana vitrectomy is actually severe inflammation, persistent elevated IOP, large or visually symptomatic lens fragments you can't leave, you have to remove. If there's vitreous hemorrhage or retinal detachment, there is no question you have to go and do a vitrectomy. Timing. Of course, retained intravitreal lens fragment and retinal detachment you have to do as early as possible. It's an emergency. Patients with corneal edema, as I said, you have to wait till the corneal edema settles, go over vitrectomy. Of course, there's little evidence whether you should do it the same day or few days later. The results have been the same. But of course, if you are experienced vitreoretinal surgeon, you have the facilities which we are set up next OT, you can straight away go and remove it. Of course, in my setup, I usually have the vitrectomy setup also in the same time in the next theater. I usually, if I have when I'm sure that I have a fair amount of lens matter released into the vitreous, what I do is I cover the eye, keep the patient, finish the list, go to the other side, get the patient ready for the vitrectomy, and straight away remove the lens matter. But if you don't have the vitrectomy facilities like me, what you can do is cover the eye, keep the patient, explain to the patient, and refer him to the visual surgeon. Of course, at least within 2 weeks of complications, better to do the vitrectomy if you are seeing any signs of inflammation. Of course, technique of pars-plana vitrectomy, of course, is the same thing. Preoperative, very dilated pupil, do a fundoscopy and see how much the amount of lens matter remaining, number and location of the leg fragments, degree of vitreous inflammation, and exclude retinal tears or detachment before your surgery. Now, during the vitrectomy, first do the co-vitrectomy, followed by removal of some soft lens matter. Then complete the clearing of vitreous from lens fragments. Now, lens fragments should not be tried to remove when it is entangled with vitreous. So, number one thing is clear the vitreous from the lens fragment. The lens fragment should be completely clear with vitreous before you use the fragmatome. And always avoid excessive vitreous traction. Now, if there is a vitreous covered with the lens fragment and if you apply the fragmatome, you will pull on the vitreous. And it might pull on the vitreous base and cause retinal tears. Now, if you find that some of the lens fragments are seated on the disc or macula, you can use PFCL, perfluorodecaline or PFCL, the heavy liquid, and float the lens fragment above the disc or the macula before applying the lens fragmatome, because it can damage the macula or disc when you try to go too close to the macula. So always use some PFCL to elevate the lens fragment above the retina. And also make sure that you use very minimum ultrasound energy to cap the nuclear fragments and phacoid, because heavy ultrasound energy can damage the macula. Now, if you have a small fragment which cannot be cut with the fragmentome, you can use your endoilluminator and crush it against the phagofragmentome and take it out. Then, once you remove the lens fragment from the vitreous, the most important thing next is to complete examination of the peripheral retina to exclude retinal tears at the end of the vitrectomy. Because you might clean everything, take the lens fragments out, and happily come out, there can be a tear remaining and cause retinal detachment later. So very important to check periphery, and if you have any suspicious place, do apply laser to those areas. So this is a video to show you how this small lens fragment can be soft. These are soft lens pattern in the vitreous. How we remove it? Can everybody see this? Hello.
Yes, sir, we can see that.
Okay.
We can see.
First, do the co-vitrectomy. Try and remove all the soft lens matter around the hard one. Try and attempt the hard lens fragment last. See now, and then try and cut as much as possible soft lens matter around the hard part. Finally, whatever you can cut with the vitreous probe only should be left, and then use the phagofragment. This is how we use the phagofragment. That is to remove the hard part. And here also remember that you have to lift it up above the retina and the macula and keep the phaco in and use minimum phacoemulsification power, ultrasound power to prevent ultrasound damage to the fovea. This is the last bit, which is getting cut with the fragmentome. If you don't have a fragmentome, you can use a phaco probe, remove the sleeve and use the phaco probe to do the same job. Now you can see that the light probe is used to crush the lens fragment sometimes. Now see that the light probe helps crush the last bit of lens fragment. Now at this point, if you are suspicious that you are going too close to the disc, you can use PFCA to elevate the lens fragment. Here in this particular case, it was not that bad, so PFCA was not used. Then finally, again use the vitrectomy probe and cut and clean the vitreous as much as possible to prevent any remaining lens fragments. That's all. Thank you. I hope that it was interesting. Any questions?
Hello? Hello? Sir, can you hear me?
Yeah, I
Hello?
can. Yeah, I can.
Just one question, sir. So once you inserted the lens under the lens matter,
Hello, yeah.
Are you changing any settings in the phaco machine, or you just use the
Not
same
here.
settings? So once you insert the lens under the lens matter or the nucleus part remaining,
Yeah.
are you changing the settings of the phaco machine or the same settings you are using?
Usually I use the same setting. In my case, of course, I'm comfortable with the foot pedal. My foot pedal
Nice.
control is so good. But of course, better to reduce the bottle height, reduce the aspiration a little bit, because sudden aspiration is difficult. Of course, generally I go with the similar settings. My habit is I don't use different settings for different lens fragments. I am so much used to control with the foot pedal and the probe. Of course, I know different surgeons have different methods of doing it, but in my case, I hardly change the settings.
Yes. Thank you.
Anybody couldn't understand anything, let me know.
Yeah. And sir, what are the precautions that you suggest when somebody handling with the last piece of the hard nucleus?
Yeah, there of course it's better to reduce the aspiration and vacuum, and those are the main things. I mean, if I let's say experienced surgeon, always reduce the aspiration, because sudden aspiration of everything is difficult. So reduce the aspiration power, increase the cutting. Cutting can be increased. Reduce the aspiration, reduce the flow, and then you have better control. If everything is okay, then we'll close the session.
Yeah. Okay, sir. Thank you so much, and thank you everyone for joining and your attention. Though little bit of interruption with the signal, I hope everybody understood with
Yeah,
the
at the beginning,
very
yes, but later it was okay.
yeah. With a very experienced surgeon, how to manage those complications. And thank you so much, sir. Have a good night, everyone.
Okay, thank you. Good evening. Good night to everybody. Right, thank you.
And thank you, sir.